for coming today. So I don't know about you, but I suspect you also see lots of seizuring animals in general practice. I certainly do in referral, and I get recurring questions from the carers. So I always thought I knew the answers. Then I thought, well, maybe I don't. You know, maybe there's some new evidence out there. And so the point of today's talk is to go over the common questions that I get asked and to try and educate and guide the client through their decisions as they try and care for their pet. So the first question is, what is idiopathic epilepsy? And excuse me, I'm just seeing my head behind the screen.
Could be neurological.
Oh, there you go. We can't kill the sound, but
because can you see the twitching there? And
I haven't said anything to Tony, but I did wonder if he had, something wrong with his head.
It certainly makes you worry. Can you see she's gone sort of big-eyed and he's not?
Yeah, because that's what he did this morning. His pupils went wide open and then he started doing this.
But there's nothing that you've got access to?
No,
Not that we
nothing.
know of.
What, chemicals and stuff?
Mm.
Yeah, but the neighbours, we've got neighbours everywhere, if they've put mouse.
yeah, we hear that a lot. The neighbours poisoned my animal. The neighbours shaved my animal. Poor old neighbours. So, what is idiopathic epilepsy? Epilepsy is recurrent seizures. That's what epilepsy means. And idiopathic is a fancy way of saying we don't actually know what caused that, madam. So, idiopathic epilepsy are recurrent seizures of no known origin. But the big deal is that these animals, cats and dogs, are normal in between the seizures. So that's what characterises idiopathic epilepsy. They are normal except they are having seizures. So it's a functional disturbance of the cerebrum. So it was interesting actually to get the sound on that video because you can hear what people are worried about. It has my cat been poisoned, has my dog been poisoned? And they're describing what they're seeing. So they're seeing big pupils, they're seeing salivation, and the animal's not really responsive to the environment. So can you tell from the type of seizure what the cause of the seizure is? The answer is no, you can't. Focal seizures, when I was training, were thought to indicate a structural lesion in the brain because a focus suggests that a focal number of neurons are disturbed, and that is why the animal's seizuring. And well, a focus has to be a brain tumour, doesn't it? I mean, but this is 30 years ago. So, times have moved on, and we realise that focal seizures do not indicate structural disease, recurrent reactive seizures, or idiopathic. So that is a focal seizure. Has anyone seen these? Hands up, don't be shy. Yes, excellent. Right, so generalised seizure. So that was filmed by a veterinary nurse, which accounts for why the camera work is so calm. But you can understand why people think their dog's dying. That's the chief concern. So generalised, the whole body's involved. And it's also no surprise these animals get quite hot. and older dogs with arthritis that have a generalised seizure, they're very stiff and lame the next day. So yeah, what does epilepsy look like? Well, it looks like a focal seizure, it looks like a generalised seizure, and the epileptic can have both, can have focal seizures and generalised seizures in their seizure pattern. So the thing is that you need to get a description of what's going on. You need to ask the carers what they've seen, what happens before, what happens after, because seizures typically have different phases. And this is vital because so many animals are referred for seizure workup when they actually don't have seizures. They might have collapsed, they might have balance disorder. One pet was referred for seizures because the head was nodding and the pet was standing there in the consult room doing the movement, which is quite unusual because I rarely see seizures happen in my consult room. So the dog's doing that. And examination showed that the poor thing had neck pain, and these were muscle spasms pulling the head down. Another case referred for seizures was a West Highland White who sat there and his head dropped. And physical exam showed the animal had a cardiac arrhythmia, so he's having third-degree AV block. And it looked like a seizure, but he's really having syncope. So there was no warning. It had the event happened rather, and then after the event, he was fine. So there's no post-ictal phase of confusion, agitation. And another animal with head dropping was a cat that was referred for hitting his chin on the floor, which is quite a story in itself. But when you saw the video, the cat would walk along and its head would just hit the ground. And what the cat was doing was narcolepsy, which is very, very rare. But there was no warning, it just happened. The event finished and the cat got up, kept going. So there was no pre-ictal and there was no post-ictal phase. So that's why coax out of your people what was going on and you might recognise the pattern. So how common is it? This is quite a hard question to answer because it depends what paper you read. Usually the general comments are 1 to 2% of the dog population have seizures from epilepsy. But then if you have a practice that deals with lots of border collies or German shepherds or Labradors, you might find that there's a higher percent. So certain breeds of dog have a higher percent or higher chance of having epilepsy. So while we say idiopathic, we don't know what it is, there is a lot of work on the genetic background of epilepsy and why does it happen. Is it a fault in the channels in the neurons? Is it a fault in the way the neurons are arranged? So yeah, cats, in the olden days there were very few papers on cats with seizures, and one of them that came out, I think Sharon Center wrote a paper, and almost 50% of these cats had something fatal going on in their cerebrum. And so the thought was cats don't get idiopathic epilepsy, cats have bad disease in their head. But time passes and people have MRI and they work up animals now, and the reality is epilepsy certainly does happen in the cat. What's striking about the cat and the papers you read is that the age of onset of the cat, idiopathic epilepsy, is quite variable from 1 to 12. So if you get an older cat with seizures, recurrent seizures, and the pet's normal in between, it could well be epileptic. So yeah, how common is it? Reasonably common. So yeah, age of onset. Books usually say in a dog it's between 3 and 5. we used to think that under 1 year of age it meant some terrible malformation or inflammatory disease, but that's not the case. But you can see from the numbers there that the older they are, the more likely they are to have developed some or acquired some kind of structural brain disease. So when the client says to me, yes, it does sound like a seizure, oh my God, is it going to die? What's going to happen? You can only tell so much from the age of onset. But if I have an 8-year-old dog that started to seizure and has been normal in between the seizures, then the chance are that the problem still could be idiopathic epilepsy. So age of onset isn't a death sentence. Just remember that. Yes, in the who gets it and who doesn't question, well, male and female dogs and cats get epilepsy. It seems to be more common in the male. And stemming on from that, a question you have is, well, if I neuter my pet, will it reduce the chance of seizures? And there have been discussions in journals on, well, estrus makes seizures more common. If we neuter our bitches, they won't seizure so much. So some papers say yes, neutering helps reduce the seizure frequency, and other papers contradict it. So I don't think we've really got an answer there on the neutering aspect. So we've established in the consult that, yes, most likely this pet does have seizures. The question I'm asked is, well, how are we going to diagnose idiopathic epilepsy? And as you can imagine, it's a case of ruling out all the other options. And where you start is the very beginning, as Julie Andrews used to say, and that is by doing lab work. There's a study on dogs that were presented for seizures for the very first time. 10% of those pets had a metabolic cause or a toxic cause. That's called reactive seizures. So, everyone loves a diagnosis. Why would you not strive for one? And when you do blood work, please do remember to submit it in the right tube, because if you don't submit your samples right, the glucose is eaten up by the red blood cells and you get hypoglycemia, which isn't real. Honestly, the number of times I've looked at the blood work and it's 2, the glucose is 2 in a seizuring dog, and you think, well, why wouldn't you recheck that? Because now we have to recheck it and make absolutely sure. So the most common cause of a reactive seizure was intoxication and hypoglycemia. Another point here, you cannot tell from the type of seizure what the diagnosis will be. So a lot of the dogs with metabolic disease had generalized seizures, and some presented in status. So this is a subject dear to my heart, the neurological exam. What that is all about, carers often say, what are you doing? When I start touching the pet, it's like, well, I'm looking to see that your pet is wired up properly, to see if it can function in a normal capacity. And what is normal after a seizure? Well, right after a seizure, these pets are very likely depressed, confused. Some have psychogenic polydipsia. And some poor things are blind for 2 weeks. And those obviously come and see me because the concern is, why hasn't this pet gone back to normal? Is there a structural reason for that neurological change? So we do the examination bearing in mind, when was the last seizure? When was the last dose of phenobarbital? When did you start the phenobarbital? Because these things can alter the way the pet reacts and moves. They're quite frightening, actually. The sensitivity of the neurological exam isn't actually 100%. So when I look at a pet and I find a normal exam, I have to bear in mind that there may still be something wrong with that brain. And what we can find are frontal lobe tumours causing seizures, but no interictal change. The months go by, and it may even be 8 months till the dog starts becoming demented and circling. So when I'm talking to the carer and we've looked at the bloods and they're normal, and we've spoken about the pet being normal at home, and then I've done an exam and, you know, still everything's normal, I can't just say, oh, fantastic, your dog's epileptic. I have to say, well, there are some animals that are normal on presentation, but actually structurally aren't. And that's important, because the next question is, well, what do we do now? You know, how are we going to find out what the future holds for my beloved animal? And you either wait, this is what we had to do in the old days, you wait and see. And time will reveal if there is a structural lesion like a tumour, because the mass grows. If there's an infarction, then you probably should see deficits at the time of the exam. If there's inflammatory disease, you normally see deficits on the exam at the time of presentation. But tumours are the major fear of owners of seizuring animals. You know, has my dog got a brain tumour? You either scan and find out, or you wait it out. And so there are always choices. So this is a very good question. So I'm going to do an MRI and I'm going to spend lots of money that I may or may not have. Is that going to find me what's wrong? Now, MRIs are actually very sensitive for finding most tumours in dogs' brains, cats' brains. They're not as sensitive for finding vascular disease, and sometimes you won't find changes associated with inflammatory disease. But the main thing we're talking about here is the idiopathic epileptic dog that's normal on the exam, that's normal at home. So how likely is it that this very expensive test with a general anaesthetic is going to secretly find a lesion? And the answer is it's very small. Now, there are the percent of older dogs that you may find a relevant lesion. So what's the chances of missing a lesion in a 7-year-old dog? Possibly 25%. You know, if you don't do a scan, you might miss a diagnosis. But this is quite important, because when the papers are written, all the MRIs are looked at, and the question is, how are we deciding if that's relevant? It's all very well saying the MRI is not normal, but is the abnormality that you see the cause of the seizure? So when we do MRI on epileptic dogs, sometimes we see postictal change, and it's called cytotoxic edema. So you see T2 hyperintensity, which is basically certain whiteness in areas of the brain, the hippocampus and in other areas, and it doesn't deform the tissue. There's no mass effect. And studies have shown that these changes will disappear with time. So reading the papers on how likely MRI is to find a lesion, they're not entirely useful. So I usually tell the carers of the normal dog, the normal interictal period, that sure, we can do an MRI, but depending on the age and the history, the chances of finding a lesion are quite small. So would you like to wait, or would you like to have peace of mind now? It's really up to you. So this is a question I have to ask myself when looking at these pets and trying to work out how much to do and how much is absolutely necessary. And spinal fluid can be very useful if you're trying to rule out inflammatory brain disease, which accounts for why I took it off the screen, but in the younger animals sometimes you'll get inflammatory disease. So do I do it when I look at epileptic dogs? Well, of course I do, because I don't know they're epileptic. And it's easier for me to do it when they're asleep under the general anaesthetic, and for me to tell the carers that, yes, this is normal as well, and the MRI's normal, and the exam's normal, and your blood work's normal, and as far as I can tell, your pet's an epileptic. If money's tight, then I won't be doing that if the scan's normal. So this is a cry for help. Is this going to happen again? You know, is this a one-off event? And the answer is yes, sometimes it is. Not many, but sometimes they just have one seizure. Who knows why? And then it stops. But as you can see, if you wait long enough, most of these dogs will have another seizure within a year. So perhaps you'll get the story of, I think my dog's had a fit, I'm not sure what to do. You check the dog, you check the blood work, you offer the advice that if it is epilepsy, then most likely you're going to see another seizure. With cats, sometimes they stop, sometimes they don't. The problem with these studies is cats and dogs that stop seizuring after one seizure never show up at the vets. You know, there's a massive population where I think, oh God, I think that was a fit. Oh, well, never mind, everything's better now. And so they don't make it into these studies. So when I have a pet that's fitting, my usual question is to sort of manage expectations and say, I'm afraid, madam, that I think, you know, you will see this again. And sometimes what the carers report is not actually the seizure, but the aftermath. So they'll come home and the pet's salivated down their front, or they've urinated or defecated in the house. Or one chap's said that $500 worth of cane furniture had been destroyed because his Labrador had thrashed about in the sitting room. So yeah, if they're looking confused and they peed on the floor, it could well be that they've had a fit when the carers are out. So this is another hopeful question. You know, we've had a few seizures. Are they going to stop by themselves? You know, so remission is the absence of symptoms or signs with or without treatment. So the signs of disease are gone. So is that ever going to happen? Am I ever going to be free of this problem? Well, the answer is it could happen. It seems quite optimistic for cats, but in the dog, it honestly depends on the breed. Border Collies, I wouldn't hold out any hope for a Border Collie to stop seizuring, and German Shepherds I've been quite worried about too. They can be very difficult to control. So the dogs that have clusters of seizures are highly unlikely to stop fitting. Their future is probably one full of seizures of different frequency. What was really interesting actually was, if I start medicating with anti-epileptics now, like now, right after the first seizure, is that going to stop them? Is that going to improve the chance of control? And what I found from the papers is no. The answer is no. There's no guarantee that starting anti-epileptic drugs soon after the first seizure will improve the seizure pattern, will stop the seizures in the future, which was a bit of an eye-opener because everyone's heard of kindling, you know, this experimental situation where the more they seizure, the more these poor little rats seizure, the more likely they are to seizure. So if you can stop the brain seizuring, that hopefully their control will be better. Well, from the myriad of papers, that doesn't appear to be the case in cats and dogs. So the relevance of this is when your patient has had a fit, do not rush to stick anti-epileptics down its throat. You really need to know what that seizure pattern becomes, because there is a chance it will only be one fit. It is a chance it will stop without any intervention at all. And the key thing, the most important thing to remember with idiopathic epilepsy is the seizure pattern is unfathomable. You know, you might have a regular period for a time and then it changes. Who knows why it changes? It might be frequent in one Labrador, it might be infrequent in the next Labrador, and they both live the same kind of lifestyle. So the seizure pattern in an idiopathic epilepsy, cat or dog, is unpredictable. So when we put drugs down an animal's throat and say that dog did not seizure because of what I did, you really have to be sort of a bit dubious. You have to think, well, was it me or was it the brain? Because what we're trying to do is improve the dog's quality of life, which brings me on to, sorry, kitty cats. Don't forget the cat. Sometimes they stop seizuring. Yes. So what was different about the cat is that some of them do seizure. And so the vets tried to reduce the medication and they started fitting again. So most of the cats, by the end of the study reported, were still on medication. So does remission happen in the idiopathic cat? Potentially. So no seizures. Next question from the carer, can I stop the medication? In a cat, you think, maybe not, let's not do that. Or if you're feeling brave, you think, okay, let's see if it works. And we slowly take it away. And the problem is seizures can happen at any point in removing the drug. And they may or may not be controllable the second time you try and treat them. So cats, it's not so clear that removing anti-epileptics is a good idea. So yeah, this is the big question. Does my pet need medication? Well, in the grand population, most of the dogs end up on anti-epileptic drugs, at least one. And in the cat, most cats are treated as well. So I'm always asked, is this forever? And that taps into the question of remission. Is it going to stop by itself? Is the medication going to be a success? Well, who knows? You just have to do it and wait. And the question is, well, how long do I wait? How long do I wait? Well, if the cat or the dog is healthy and all you're looking at is the seizure pattern, then if the pet hasn't seizured for a year or 2 years, perhaps the brain has stopped fitting. So perhaps you can reduce the drugs. And you reduce the drugs slowly. There's no other way of saying it. And different papers say I reduce it by 50% every half-life, or 30%, or depending on the tablet size. I think the key is over months. You just watch them and see what they do. So, excellent. So now we're going to do a bit of carbohydrate-based learning, and I need some volunteers, because what we're going to talk about now is the seizure pattern in epilepsy, and how long is a bit of string. So you're trying to pretend you're not here. I'd like you to do that with that. If you stand up for me, please. Sorry, what's your name?
Katie.
Katie, thanks, Katie. So that is one end. And these, my friends, are seizures. This is a seizure. And this is another seizure. And here's a few more. So this is we're going to thread some bagels on a string, but you've not seen this at the BSAVA. So fun and games. So just bear with me. You can have these later if you like. I think they're vegan. But right then, it's fun, isn't it, Katie? You've never done this before. All right, so this is one hell of a seizure pattern coming up. Thank you. What's your name?
Undine.
Pardon?
Undine.
Undine, thanks very much. Do not let go. Do you want to pull that tight then for me? So, okay, here we go. So these are seizures, and this is time, right? String theory, this is time. So how long is a piece of string? Well, seizure patterns. So hang on tight. And not very random at the moment, but this is what we'll do. So how about that? That is a seizure pattern. So I'm going to ask someone, would you treat that seizure pattern? Would you treat that seizure pattern? Would you put anti-epileptics into that treatment? Ah, exactly. Very good point. I like the way you think. Right, so this is a seizure. Now the question is, how long is that seizure? How wide is that time measured? How long is this? So not only do we want to know how many seizures are happening, we want to know in what time frame, don't we? Yeah, so what else do we want to know when we're talking to someone over the phone about their dog's seizures? Yeah. Because what's going on here? Clusters. Yes, repeated seizures. Now, imagine this. This is a hell of a day, isn't it? What is that? Go on, say the word. Status. Yeah, that's quite possibly status epilepsy. We'll get to that in a moment. But so your patient has seizures like this. Would you medicate that? Yeah, because we don't think that's a good idea. You know, imagine that little fluffy black dog seizuring all day. You know, heat stroke, urine everywhere. It's just messy. So the other thing that you can't see is the post-ictal period. Because imagine this, right? So this is bad news. We're not mad on this either. A lot of clusters, a lot of clusters, a lot of clusters. You know, that might be a day. You know, that might be 2 days. Now imagine this. Let's give you some of those up there. I love this, it's really fun. So, okay. So they're the seizures. And you think, oh, look, if that's a month, you know, if that's a week, yeah, put up with that. It's not in my house. It's not on my Persian rug. No, seriously. You think that's spread out. Would I medicate that? Have I got enough information? Well, firstly, how long is the bit of string, time-wise? And how long are those? But also, how long is the recovery period? Because imagine if that seizure, that poor dog was howling and barking and slamming into furniture until this one happened. And then the seizure, the physical activity stopped, and the same thing happened again. He's confused, does not recognise his carers, and has them bowed up against the wall because he's going to attack them. We've had that story before. And then after this one, well, who knows? You know, maybe he's run out in the garden and he's got lost. Or if this is the cat having seizures, gets out the cat flap and gets lost, you know, that it's not just about this, it's about what happens after. So when we look at the seizure pattern, we want to know everything, don't we? How many bagels on a string and what's happening in between them. So treatment-wise, I think you're thinking the right things. You're thinking about how long is this bit of string? How many bagels are happening together? Well, when we look at the definition of success, how do you define successful treatment?
Good quality of life?
Yeah. Well, how do you define that? Well, I'll show you what vets define it as, what the pharmaceutical success rate is defined by. So there's 4 there. There's 4 there. So there you go. I'm going to ask you to relax that, and we're going to take those off. They can go on the floor. It's not a crisis. And then you've got there. That is 50% reduction of seizures. So that's what vets call a success. That's how it's defined. So when you look at phenobarbital and they say 60 to 80% chance of success, all you've done is take 6 bagels off the string. You know, this is still going on. So is that a success? That's a cluster. The answer is no. I beg your pardon, it could be status. This is a cluster of seizures. That's not terribly successful either. If you'd like one, you know, if this is a week, maybe that's okay. If it's a month, if it's a year. So success to the person looking after the animal is very subjective. To the vets, we're measuring it by numbers, by the actual number of seizures. So thanks, that's lovely. Thanks, ladies. We'll put the bagels away. So, there you go. Yeah, we do like a reward. Thanks. Pardon me. So, what is a success? What does successful treatment look like? It means 2 different things. What you're saying, success, to your carer is not what they're hearing. And to the person who said quality of life out the back, there you go. So quality of life is what we're striving for. 60% of carers of epileptic dogs said their quality of life had deteriorated. And if the carer's quality of life deteriorates, it means the lifespan of that animal is reduced. And reduce means ending in euthanasia. So quality of life, you need to know what your carers define, what they'll put up with, basically. So studies now are focusing on that, thank goodness. And Lego vets think that half the number of fits, that's how we're trained. That's actually quite good, you know. But status, clusters, and side effects of medication are not acceptable. Having said that, what we do know from a practical point of view is that the medications, the anti-epileptic drugs we use, they can reduce the post-ictal period. So instead of running around the house howling for 2 hours, that can be shortened down to maybe 10 minutes, 15 minutes. Bit tired, bit wobbly, bit confused, sleeps it off. The next day it's much better. So while testing medication to see if it actually benefits a pet was measured in counting seizure numbers, over the last few decades vets have realised that the medication benefits actually are on the whole seizure phase, cutting the ictus down, cutting down the post-ictal period. So what was interesting about cats, try and get a tablet in a cat and your quality of life really plummets. So there are some transdermal medications being developed in the in the US, and they are absorbed through the skin, but also the cat licks its paw and gets it in that way. So hopefully they'll become available in the UK at some point. So there are general guidelines, and you've touched on those. We're fiddling about with a bit of string. So frequent seizures, clusters of seizures, status. But yeah, recurrent seizures is the clue. There was a study years ago on, I think, vigabatrin, and the people were told, well, basically the dogs were so badly controlled that either the drug was going to work or the dog was going to be euthanized. So the people joined the study on that basis, and they were given the drug to medicate their pet, and it didn't work. It didn't cut down the number of seizures, but the carers moved the goalposts and said, I'll accept this, because when faced with euthanasia, I've changed my mind, and I will accept this now. So with treating epileptic animals, you really have to keep in touch with the carers, because their goalposts move. What are your expectations? What are your hopes? How do you feel about that now? And that support of the carer keeps the pet alive. And I know for a fact that the carers want consistency in who they see. So if it's all possible in a practice, if you, as much as you are fearful of neurology, if you do get the epileptic pet, do try and hang on to that patient as your own, so you can establish that rapport with the people and have consistency for them and for the pet. Because the carers tell me they're frustrated seeing different people all the time. I see from the notes that every time, sometimes, when the pet sees different vets, each vet changes the medication. They don't know the pet, the dog's fitting, some action needs to be done, I'll give it more, I'll just give it more, just keep sticking drugs down this dog's throat. The reality of the epileptic patient is they will always seizure, pretty much. So seizuring is part of the disease. We need to think about the string and decide, does this dog or cat really need more medication? So if you can, it takes a lot of time, but if you can maintain that contact with the carer, it's going to reduce their stress, it's going to educate them on what to expect, how to look after their pet, and as a result the pet will have a longer lifespan. So yes, what to use. Thankfully we've got a few now. Phenobarb is still probably the most common. You know not to use bromide in the cat because of the pulmonary disease. They start coughing. Pexien's safe. What we found with Pexien is a high dose seems to cut down the number of seizures more than the lower dose. Who uses Pexien? And this won't get back to Boehringer, but what do you think of it? Do you think you got a head nod there? Yeah, is that your gut reaction? Yeah, I've heard similar. So what do? Well, creature of habit, I must admit, I use phenobarbital. It gives me a strange sense of control in an uncontrollable disease. So I can measure it and dose the pet, and then I can measure how much is going around the bloodstream, and I feel that I'm making empirical decisions. But in all seriousness, the decades of use, very few side effects, long-term damaging side effects from phenobarbital. I have started flirting with Pexion to just sort of see how it goes, but I'm not sure. So what else? I think what put me off about Pexion was this paper I read. Pardon me. So imagine the scenario, the dog goes on Pexion and the seizure pattern's not great. You think, well, this has gone on long enough, let's see if we can make the pattern look a bit better. Stick phenobarb in, and then the pattern improves, seizure pattern improves. You think, gosh, that's good. Do I really need to use Pexion anymore? Oh, I'm a bit frightened. And the paper said that dogs on I think on phenobarb and bromide, but anyway, Pexion was in the mix, probably the first drug used, and they took away the Pexion, and it had no effect on the seizure pattern at all. And I was a little bit concerned, just thinking, well, is it actually doing anything at all? So, but that's just one paper, and the more papers you read, the more you realise that you should just stop reading too many papers because they contradict each other to a certain degree. But Boehringer did a lot of work on it. It's safe, it works in cats and dogs, and I certainly don't discount it. Kepra's quite nice, you can inject it, which is helpful in status. In cats, there's not that honeymoon period, they don't seem to get accustomed to it, so the chronic control of seizures in cats, Kepra might work, but giving tablets to a cat 3 times a day is pretty harsh. So another question is, well, I've put my cat on these medications, how successful is this likely to be? Some of them it just doesn't work. And the thought is, after you've tried 2 drugs, 3 drugs might not work either. They've defined themselves by not reacting to 2 medications as being difficult to treat. So you add a 3rd one in and you think, what success have I got? Well, actually, a 1/3 of the ones you give an extra drug actually do improve. So never lose hope. I think that's the thing. It's easy to get cynical, but really keep going. So complications. So the next question is the medication going to hurt my pet? Is it going to make it really ill? And the fear is liver disease. So an animal on chronic anticonvulsants, usually we look at them every 6 months. It's an empirical decision. Just choose 6 months and keep an eye on their liver function, blood ammonia, bile acids, urine. But the most common idiosyncratic reaction to phenobarbital is actually the blood dyscrasias, where they have anemia or pancytopenia. So the platelets might drop, white cells might drop, red cells might drop. The whole shooting match might just get suppressed. They present like ill dogs. So if you have an animal on chronic anticonvulsant drugs and they present as not being well, you should really do haematology and biochemistry and look at the organs that metabolize the drug, so liver and kidney. So get urine as well. When you remove the phenobarbital, the bone marrow responds and starts working again. There have been cases of idiosyncratic liver failure where the dog's phenobarbital level has been within the reference range. Dog's been absolutely healthy, and boom, it just fails. So that comes out of the blue, and it is very rare. So a raised ALT, a raised ALP, and the dog's running around looking healthy is not idiosyncratic liver failure. So, yeah, pancreatitis, that's a huge concern, and is it related to phenobarbital and bromide use? It certainly says so in the journal, and then when you read the journal, you realise all the dogs are fat, and fat dogs get pancreatitis, and you think, oh, cart before the horse. And so the paper says, well, actually, the problem with this study was, although the numbers of the CPLI were up, we didn't know if they vomited or had abdominal pain or diarrhoea. So from the studies, it's not entirely sure. So if I have a healthy pet with lots of seizures, dog, I will medicate it with phenobarbital and bromide. If it's a schnauzer, I might be a bit concerned. What does that mean? I'll have to weigh up the odds and look through the history and say, has the pet had pancreatitis? What's its triglyceride level? Is there any other option? And maybe I would reach for Pexi, and maybe I would reach for Keppra. But it's a balance of evils, isn't it? So try and keep the dog slender is probably going to reduce the risk of pancreatitis. So it's a huge worry. You've seen the fluffy black dog seizuring, like it's just going to die. It's not going to end well. Most dogs don't actually die in a seizure. The prof that taught me was telling me this story, and a resident before me said to the carer, oh, madam, no, it's rare that the dogs die in a seizure. And honestly, the dog just dropped dead in front of the carer right there and then. So sudden death in epilepsy in humans is a known problem. It's suspected as occurring in dogs, but it's very, very rare. So in the human, I think they have chronic seizures. I think they might be male, and they die in a fit. In the pets, they die because the carers just can't take it anymore, and they euthanize them. So yeah, seizures are, in that respect, dangerous. So what is most dangerous to the patient? It's cluster seizures. Seizures that are repetitive. The animal recovers in between, but they're very close together. It'd be nice if we knew which animal was going to do that. The short answer is we can't tell. Most epileptic dogs will have a period of cluster seizures in their life, and it's rarely due to low serum levels of phenobarbital. I mean, the sensible thing to do is to check the serum phenobarbital level, but that's rarely why. And I think it underlines how difficult it is to predict the seizure pattern of an epileptic, to know what the brain is going to do, whether it's going to go crazy or whether it's going to stop fitting altogether. The question of neutering the dog to control the cluster seizures, some people say yes, it helps, and others say it doesn't. I think looking at the big picture is important. Are you going to breed a seizuring dog? And the answer is no. Are you going to neuter a female dog anyway? Probably. Are you going to neuter a male dog? Well, depends, maybe. So we haven't got decent numbers to give you a decent answer on that one. If you think as vets that it will benefit the pet's health to neuter them, then carry on. So, yeah, status, that's a nightmare. So what is it? The repeated fits from which they don't recover, consciousness, and cats and dogs. I guess what was interesting was the fact that it can occur as the first manifestation of idiopathic epilepsy. I mean, the temptation is to imagine that the dog's been poisoned. It's the neighbours again, they've chucked something over the fence. But yes, it could be a poison, it could be structural epilepsy, or it could be from idiopathic epilepsy. So if a pet started with status, I would absolutely give them anticonvulsants, and the reason is technically I know they're supposed to cut down the number of seizures, but I also know they're supposed to shorten the recovery period. So if there's anything I can do to stop that happening again, I will. And do I load them? Do I fill them up with phenobarbital? Yes, usually. And the pet stays in hospital during that period. But you knew that. I mean, I think the question in all their minds is, well, what am I going to do? What's the treatment? What's the recipe? There isn't one answer. I think you start with benzodiazepines, you move on to Keppra, it's quite expensive, it's a short-term fix. Propofol if you're struggling to stop the physical movement, but you need to suppress the epileptic, the seizure activity in the brain, so you do need to give them phenobarbital, and you just keep them on the right side of a coma, basically. You try and protect their swallowing, but if that goes, you need to tube them. So I think, we have an emergency room downstairs, so that's the kind of case I'd be keen on referring if I was in general practice, just because they are very, very tiring, all-consuming 24 hours, and we just don't know when they're going to stop. We don't know if they're going to regurgitate or do anything fun like that, and we need to make sure they pee as well. Some pets post-ictally are really confused and they just forget to pee and get a large bladder, and you get secondary problems. So yeah, we're almost at the end of the consult we've had with the client, and we've said, this is what epilepsy is, madam. It looks like this, it can be like that. It may stop, it may only be one seizure. Most pets go on to fit. Most pets need medication, but we won't do it at the first seizure unless you present with status or a cluster. And the next thing is, do we want to investigate your pet? Well, it depends on how old, what's been going on at home, what the neuro exam is, what your desires are. What's your bottom line? What are you happy with? A lot of the people that come here do actually come after the first seizure because they're really, really scared. And I have the benefit usually of time from the time the first fit happened, and the panic and fear is acute, and the pet's recovered. So they come and see me and they're a little bit calmer, and we have a chat and we go through all of this. And some decide to investigate and some decide not to, but they all leave feeling that they know more, they feel more in control. They've got their tuberectal diazepam as well. So there's that sense that all is, I can do something to help my own animal. And then they can call up and we can have another chat if they forget things. There's a lot of chat going on with epilepsy. So don't knock it. They do need a consult, and if they decide not to progress and do MRI, then we can put that on the back burner. So yeah, what do I advise? I think probably what you do. Don't breed your dog, keep it slender, medicate if necessary. Always have some skepticism of, has this pet improve without me or with me helping it? And do I absolutely need to put more drugs down the throat or not? Will this pattern come down by itself? So chiefly, always ask the carer what they want. where are they? Are they comfortable? Do they want to do something different? And I think you'll probably have success. So that's my experience of dealing with people that own seizuring cats and dogs.